Welcome to Pursuing Quality Long-Term Care, an educational podcast for individuals needing long-term care and their families. Join us as we talk with national experts and advocates about strategies you can use in the pursuit of quality long-term care. This podcast is a program of the National Consumer Voice for Quality Long-Term Care. Consumer Voice is a nonprofit organization and depends on our members and donors for support. To contribute to this podcast and our work, make a donation at theconsumervoice.org/donate. Every dollar helps. In this episode, Consumer Voice's Public Policy Director Sam Brooks talks with Dr. Norma Coe, a professor of medical ethics and health policy, whose research on the minimum staffing rule in nursing homes found that the rule would save 13,000 resident lives annually. Sam and Dr. Coe will discuss the rule, its impacts on residents, and the current barriers to its implementation.
Hello, everyone, and thanks for joining today for this really important podcast. We have Dr. Norma Coe here today to talk with us about the minimum staffing rule. As many of you well know, last year, President Biden implemented through CMS a minimum staffing rule that would require nursing homes to have at least a certain amount of care per resident per day. This is comes after decades of advocacy from nursing home residents, academics, Consumer Voice, and other groups. And currently that rule is under threat, and both in the courts and in Congress. And we're just really excited to have Dr. Coe with us today, who just authored some great research on this rule, which we'll get to. And she also recently had a wonderful op-ed in the New York Times with her fellow researcher, Dr. Rachel Warner. And we're just really honored to have her here today. So to introduce Dr. Coe, she is a professor of medical ethics and health policy at the Perleman School of Medicine, the director of research at Penn LDI, and co-director of the Population Aging Research Center. Her research interests are in health economics and public finance. Dr. Coe's work strives to identify causal effects of policies and directly and indirectly impact health, human behavior, healthcare access, and healthcare utilization. A major focus of her research has been long-term care access, costs, insurance, and delivery, with a particular emphasis on people living with Alzheimer's disease and related dementias. Dr. Coe holds a PhD in economics from the Massachusetts Institute of Technology. So thank you so much, Doctor, for being here. We're really glad to have you. I know you're on sabbatical and you're in another country, so we're really honored that you would take the time to be here with us. Thank you.
Yeah, thanks for having me. It's a pleasure.
So let's jump right in and talk about I was really excited, your op-ed. I was really excited to see your op-ed in the New York Times titled Your Parents Deserve More from Their Nursing Home. And we'll share that when we with that link with the podcast. Can you talk a little bit about why you wrote this and why staffing is so crucial to nursing home residents?
Yeah, so we were very fortunate to be approached by Senator Warren's office, who was, facing the same barrage as everyone else about what is the research, what would the staffing rule do, would it be good, would it be bad, how much it would cost, and basically looking for any information that we could find. And so Dr. Werner and I basically looked into it, and we tried to figure out from existing literature, what would the effect be on the health of the residents within nursing homes. And so we used existing research, existing numbers from the literature, and we had current data on the staffing records and staffing administrative records from nursing homes, and basically tried to calculate the effects that would happen on something as dramatic as mortality. There's lots of research that shows that staffing is correlated, higher staffing ratios are correlated with better outcomes, but we really wanted to see what the causal evidence would say, even as something as major as a mortality outcome.
Great. And there's not much research out there saying that less staffing is better, which makes our case much easier. So before we get to the research you did, let's talk a little bit about this rule that has caused such controversy. Um, it was announced really in 2022. President Biden announced really an ambitious set of nursing home reforms. I think those came out of the pandemic, where over 200,000 residents died, and residents and workers died, and there was really this groundswell of momentum to do some reform. Unfortunately, some of that has gone through, but it's also really hit a wall. Could you talk? So the final rule was promulgated last year or finalized last year. It's going to be years before it's fully implemented. Could you talk a little bit about what that rule looks like, what it will mean on the ground for residents?
Sure. So the rule itself is framed in terms of hours per resident day, and there's now going to be, for the first time at the federal level, a minimum number of hours per resident day that the nursing staffing ratio has to be. So total nursing is 3.48 hours per resident day, and then they have it broken down by different types of nursing as well, so that you can't do it all sort of with just nursing aides. There are some standards on RNs, and nurses have to be on site 4 hours a day. For some, 3.5 hours per resident day may sound like a lot. For some, that may sound like a little. I don't know, it depends on where you come from. But based on the numbers we saw from administrative records, only about 20% of nursing homes in the US currently meet that standard. So it would mean a dramatic change in staffing for most nursing homes in the US.
Right. So when you say the standard meet all, do you mean all three of the requirements?
All three of the requirements, yeah.
Yeah, so
Yeah.
the component
But there
parts
isn't
of
there isn't a minimum standard now, so you kind of can't blame them for not meeting the standard.
right, right,
And
right,
there's another, so like I said, 20%, only 20% make it. There's another like 13-14%. They're actually pretty close.
right.
So for those, they wouldn't have to change their staffing dramatically. For some others, they would have to have some hiring.
Yeah, I think when you look at the numbers, exactly like you say, I mean, frankly, the national average is higher for the total, like I think it's about 3.56. But when you get into the particular numbers, you're, I mean, there will be some reshifting, and I think it's important, and I imagine you agree with this, is that this is a floor, as you said. This is not, a lot of people have said, oh, they'll just staff to this, but CMS clearly made clear in the rule that this is a floor and that many residents will need higher levels of care, correct?
Yes, and if you look at, some states have staffing minimums already. California has had them for
Sure,
for decades, and you can see variation in California nursing homes. They did not all go to the minimum staffing
right.
level. The regulations do increase those who were not meeting the minimums, but you don't see a huge drop among those who are staffing at higher levels to begin with.
Yeah, and I think that's important to point out. I'm glad you did. I mean, California has a 3.4, I think, is their minimum staffing, and for frankly, Washington D.C. has 4.1, and we haven't seen a catastrophic deluge of closures, have we? I mean, we've seen, and if anything, this rule, both in California and this federal, it provides for exemptions. Are you familiar with the exemption process or what those are
I know about the
in the rule?
exemption rules, yeah, and they're actually, I thought I was when I first saw the rules, I thought they were quite generous, right? So,
Yeah.
rural areas get an extra year to actually meet the minimum standard. And then there's also a process that you can go through if you really can't find the staffing, and there's documented reasonable reasons why you can't meet this minimum. They won't hold you to it. And so I feel like, they try to get the best of both worlds, where we want to have standards, we want to have targets, but we realize, especially under current scenarios, finding that are trained to work in nursing homes may not be the easiest thing in all areas. And so there's a little bit of wiggle room to try to adjust for the current state of affairs.
Yeah, I think you agreed. I mean, we're very consumer focused and opposed really any waivers, but when you look at these waivers, they do take into account rurality, the idea they don't want to shut down facilities who can't hire folks, right? Who are making good faith efforts. I think that's one of the points that get lost in this discussion is that CMS isn't going to be shutting down folks or even finding folks that really showing that they're making a good faith effort but can't hire those folks.
Exactly.
So would you would you characterize this as an extreme rule? I think the industry has said, "Oh, this is just way too, I mean, high." And do you think nursing homes can meet these standards?
I think by and large, especially given the delay in the timing from when they know about the rule and when they have to actually meet it, I think with that time, the vast majority of nursing homes should be able to meet this rule. No one can foresee the future on what's going to happen
Right.
with the workforce, so there's always that caveat. But I think the vast majority of nursing homes could meet this rule. Like I said, 20% currently do. That's, almost another 20%. It's like 15% or so, are pretty close to meeting it already. So there's, another swath of nursing homes we just don't even need to worry about. They don't have to make any
Right.
changes. And then there's a lot of talk about where the financing will come from because it is some argue it's an unfunded mandate. There is money for training in the bill,
Right.
so it's not unfunded in that way. But there's currently no talk of extra money to help nursing homes meet these requirements. But there's also a lot of concern about where the profits of nursing homes are going in the first place. And so I do think that there's money around that people can use for staffing and actually the increase the outcomes and their primary mission is to take care of residents, and I think there's some money that they can reallocate for staff.
Yeah, we agree with you. And we're glad that you brought that up in your op-ed. When we have been talking about the rule as a kind of a comparison point, we've been breaking down how for-profit home staff compared to, say, nonprofit homes, and there's really a profound difference. Generally on an hour, nonprofit homes staff about an hour higher on average. Not all nonprofits do, than for-profit homes, and more, and I think there's ample evidence for this, is who owns a nursing home is the predictor of care quality. And could you talk a little bit more about, and you talked about the Alensky paper, I think, and the Gandhi paper about the diversion of funds and what you mean by that?
Yeah, so I think it's fascinating work done by colleagues of mine, not myself, so I take no credit in it, but fascinating work. They looked at reports coming out of, oh, no, like, is it Indiana?
Illinois, I think it was. Yeah,
Illinois,
yeah,
sorry.
Illinois. Yeah,
One state actually was able to had a reporting that you could look and see where ownership, nursing home ownership, and what they co-owned, which was the key
yeah,
for their study, where they basically can look and see at transfer payments. So if a for-profit nursing home also owns the food service company, you see that the payments to those type of in those type of arrangements are much higher for the services that are co-owned by the nursing home. And so they argue, and I don't have any reason not to believe it, that this is a way to essentially hide your profits as a for-profit nursing home. So you co-own the laundry, or you own the food service, something like that, and then increase the payments to that entity then is able to claim the profit. You own it, and so therefore it looks like your nursing home isn't doing well from a profit standpoint. You don't have to worry about that, but they're essentially, they call it tunneling your profits to a
yeah,
different business
yeah.
organization, and that way it looks like you're not making a profit. You can't possibly change the spending within the nursing home, but essentially you are still pocketing some of the money.
Thank you. That's a great thing. If anyone is, for those of you listening who follow Consumer Voice, I think you'll know that we are rabid about related parties and tunneling. And we were really happy to see that paper. I think it was one of the first papers that really got down into to the this of course is an academic term, the nitty gritty, and found that, I think they said 60% of profits are being tunneled or hidden. So we're talking billions of dollars. And so we also advocate, and I think this is something you work on as well, is greater transparency. We need to know where this money is going.
And
And
ownership, right?
right, right. I mean, CMS doesn't know who owns some nursing homes, right? I mean, and they're supposedly the license agency. So it's very frustrating. So let's get back to the request by Dr. Warren. And just your interesting analysis and really profound analysis on the impact on residents. Could you just walk us through it and what you found? And again, what Senator Warren, I think what her request was, and how you went through and what you found in your research?
Sure. So, I mean, she was really just looking for ways to quantify, if we could quantify at all, the effect of the staffing ratio on patients, or the rule on patient outcomes. There's a lot, like I mentioned earlier, there's a lot of literature showing the an association, like if higher staffing nursing homes have better outcomes, but there's a lot of problems with that because if you can select a nursing home, select one that has a lot of staff, but you're also probably richer and you're also probably healthier. And
Sure.
so, you have a selection issue going on. And so we really wanted to get at what could be the effect of sort of exogenous changes in staffing that this rule would cause. And so we went through the literature. We looked to see what was the most compelling arguments and compelling identification strategies to say that this is actually getting at the causal relationship. And we landed on essentially earlier work by Patricia Tong, who studied the California changes in 2000. Where they changed the staffing rules so that it increased the total staffing mandate from 3 to 3.2. It also had some nitty-gritty changes about exactly how you count hours. And so in reality, it was going to be a much bigger change than just a 0.2 increase in the hours per resident day. But that seemed the most fitting for what we were trying to do. It had an exogenous policy change. It was a staffing minimum rule, and so we thought that was the best one to go with. And it had a very quantifiable outcome in the number of deaths that would be prevented with the higher staffing. And so we then took that number, the number from that paper, and matched it to essentially looking at the payroll data from 2023 to see how many nursing homes were meeting the standard versus not meeting the standard. How much more would they actually have to increase staffing in order to meet the standard, and then apply the effect found in that paper. So if you had to increase your staffing by 0.2 or 0.4, you have a different effect on each on your mortality rate. And so what we found is overall that we think that passing this rule and actually implementing it, not just passing it, but implementing the rule, would save about 13,000 lives annually.
Amazing, amazing. When we saw that, we couldn't believe it, and it was really a first of its analysis on this rule, and one that we have, as I told you before we recorded, have really lifted up. And
I have to
tried
admit, it
to,
surprised us at first too. We
yeah,
were like, do we have a decimal point in the wrong number, in the wrong
right,
place? And so, yeah, it's large, and that's not including all the other things that we do
yeah,
know, like urinary tract infections
right,
and bed sores. And there's a lot of other different outcomes that are a little bit harder to quantify in terms of like, a
right,
quality of life metric or things like that.
sure.
And so this was sort of the most direct and easiest way. And it's a big effect.
And I think that's so important. I mean, 13,000 lives is powerful in and of itself. But, when we talk with residents who are living in nursing homes with low staffing, it's quality of life. Sometimes they don't get out of bed all day, or they have to sit in their own excrement because there isn't enough staff to come change their diapers. And that is, um, uh, not, I mean, that is something that people just, I don't think, realize. When we're talking about point two or point one, we're talking about minutes here of care, which equates to getting dressed, bathing, um, transferring out of bed. And I think that that's something that it's hard to quantify um, when you compare it to your research. But hopefully there will be more. If the rule is implemented, we'll have more evidence of its impact on outcomes. So where there's an effort now um, to block this rule, and some in Congress want to use it as what they call a pay for. A bill that would have blocked the rule last year was scored by the Congressional Budget Office as um, uh, saving the government $22 billion. But that was mostly an enforcement cost. And I know your paper didn't look at this, but when you're over 10 years, we're talking about 130,000 lives that this rule would save, and just countless less, adverse events. Um, I don't know if you looked at costs at all, or can you imagine or even think about, and I may be getting out over my skis here a bit, you know, the savings to families and to the Medicare and Medicaid program um, of a rule that saves 13,000 lives a year. And I don't know if you looked at that, or you're even in a space to talk about it.
Yeah, I mean, we didn't look at the costs. I know that the estimates range between, 4.3 to $6.5 billion a year in order to do the entire thing. And like you said, it's some of it is enforcement, some of it's not just the
Yeah,
staff that need to be hired.
right,
But again, if the tunneling story is true, there's profits
right,
there that can be sort of recaptured and used for patient outcomes, and for resident safety, quite honestly. And so I think there's who's paying for it maybe a bit of a sticky question, because if it's coming out of sort of profits that are currently hidden, that's a different story than if it's really coming out of sort of taxpayer dollars or Medicare or Medicaid, right? There, like I said earlier, there's no increase in the budget for those
right,
programs,
right,
so there's no direct cost necessarily for the
right,
staff
right.
themselves.
Dr. Norma Coe, I want to thank you for joining us today. Your study has been so important for pointing out just how critical this rule is to nursing home care, and how many thousands of lives can be saved um, through um, through its implementation. For those of you listening, this rule is in dire straits. It is being attacked on a variety of fronts right now, but right now the most pressing concern is in Congress, where both the House and the Senate are looking to block this rule in order to try to save money for other priorities. We need your voice to be heard, and that means reaching out to your members of Congress and telling them, no, do not oppose the implementation of this rule. Do not block this rule. You can go to our website, and we'll share in the information on the information for this podcast an easy way that you can contact them through email or through calling. We ask that you do both. These are critical times, and the rule could very well go away, unfortunately, unless we make our voices heard. Let's be the voices of residents, let's be the voices of families, and let's be the voices of workers. And let's make sure that this rule is implemented. Thanks to all you for listening. Thanks again to Dr. Norma Coe and her great work, and to her partner in the study, Dr. Rachel Warren. And please come back for more podcasts. Thank you very much. Bye-bye.
Thanks so much for having me.
Thanks for joining us on Pursuing Quality Long-Term Care. This podcast is a program of the National Consumer Voice for Quality Long-Term Care. Consumer Voice is a nonprofit organization and depends on our members and donors for support. To contribute to this podcast and our work, make a donation at theconsumervoice.org/donate. Every dollar helps. And make sure to visit our website, theconsumervoice.org/pursuingquality, where you can subscribe to the podcast, follow us on social media, and find more information and resources. If you enjoy the podcast, please rate, review, and subscribe. Thanks for listening, and we'll see you next episode.